Giving people an introduction and getting people up to speed with primary care networks can be a real challenge. Today's video is an interview I did with a GP associate at our local training hub to serve as an introduction for first 5 GPs to primary care networks and the role of being a primary care network clinical director. I talk about my experience working as a primary care network clinical director over the last 2 to 3 years. I'm currently exiting the role, so I have a chance to be reflective and in an honest mood about things. I think this video serves as a good and fairly detailed at times introduction to primary care networks for an informed audience, perhaps practice staff, GPs, people taking up roles in primary care networks, or those who have just have a general interest. We cover a lot. What is a primary care network? What are they required to do? How are PCNs funded? Identity and branding, how to set priorities, the impact of COVID on primary care network development, lessons in leadership from running a primary care network, managing stakeholders, including those practices, supporting a crisis response, COVID, motivating people, and the main challenges and the main successes that I feel I've encountered. If you don't want to do the whole thing in one sitting, please do use the timestamps to navigate to what you feel is interesting. I really do hope you enjoy this interview.
Hi,
morning, James.
Good morning. So I'm very happy to be here and joined by Dr. Andy Foster, who is a colleague of mine. We both work in the same practice, and has also been the PCN lead for PCN1. And he's been very kindly agreed to talk to us today, although he can't be with us on the evening. So thank you so much for joining us, Andy.
Yeah, hi, James. Yeah, it's always great to have an opportunity to speak to First Five and younger GP colleagues. So really great to be included here. Where do you want to start? I'm at your disposal to talk about primary care networks.
Well, that's great. We're very grateful to have your experience and expertise here. I mean, I suppose the best place to start is if you'd like to introduce yourself a little bit about your impact with the PCN and about the other things that you do, because you've got quite a portfolio going on.
Yeah, so I've got a slide, just a declaration of interests in a way, really. So I'm a GP partner, work with you at Parkside Medical Practice. I'm one of the directors at NCGPA, the Federation. I'm the exiting primary care network clinical director for Bulwell and Top Valley Primary Care Network. So I've been doing that job for about 2.5 years, and I'm just working some notice and exiting to move on to new things going forwards. Work with the Royal College. I've paid up my membership fee this year, and I'm still a member. I like to engage the local college, do a bit of podcasting and vlogging, and getting involved with Deep End General Practice in Nottingham as well, who are doing really, really great work. So I guess that's me. There we go.
Well, that's it. I mean, and also all of the technology and podcasting stuff, and that there's lots and lots of great videos on the internet. From you guys, and you and Dr. Gandalf for tech and things that are going on. So definitely worth checking that out. So Andy, I suppose the best place to start is a little bit about what the primary care network is, a bit about its aspirations. How have we ended up with PCNs?
Good, yeah. So it's a very good place to start, really. So primary care networks have been around since 2019 with the introduction of the primary care network DES, Direct Enhanced Service Contract, which all practices were encouraged to sign up to. The idea really is that it's about grouping existing health and social services, sort of GP practice and so forth, around populations of roughly 50,000 patients. And the idea is that a population of 50,000 should be big enough so that you can achieve some economies of scale by targeting resources at that population and that size of population, but also small enough so that you can be sensitive to the unique identity and the unique health and other needs of that population, so that you can really tailor and personalize services to them. So that's the idea. Another way to think about it is really about the levels of primary care and NHS services that exist at the moment. So at the bottom, people are talking about in terms of neighbourhoods, 50,000 patients. Above that sit the ICPs, the integrated care partnerships, and they're around sort of hundreds of thousands of patients. So in Nottingham, we have Nottingham City ICP, which is about 360,000 patients that live within the Nottingham City boundary. And then bigger than that in population sizes of sort of million plus ish, you have the ICSs that I think are going to be renamed ICBs in the near future. And we have sort of Nottinghamshire ICS, which comprises 3 ICPs. And that's thinking about it really at that level. Another way to look at it is more around, you asked about aspirations. So this picture on the right encapsulates, I think, some of those aspirations. And the idea is to wrap, through using the primary care networks, all of the health and wellbeing services that a person might access, to wrap them around that person and that community in order to improve their health and also their well-being as well. I think that's really well encapsulated in this picture, really, looking at the GP surgeries, then the other health organizations, and also just illustrating that the idea is to reach out to churches, council services like leisure centres, child health groups, midwives, district nursing, all of these things that are involved in people's health. The aspiration is to involve them in some way with the primary care network and its objectives as well. So those are the aspirations.
Sort of joined up care, isn't it? And I think that the diagram here really illustrates just how many different organizations it takes to look after people's care. And I think there's perhaps a diagram coming up later just showing those different aspects that you've got to think about to make sure that we're looking after people's health.
Yeah, absolutely. The other side of it is technically what is a primary care network, because I understand we've got quite a specialist audience here with us today. And so a primary care network is technically, officially, a collaboration of the GP practice in a certain area, and they sign up to a collaboration agreement which allows them to receive the resources that fund a primary care network in return for collectively together delivering the objectives that are asked of a primary care network. So a primary care network isn't actually an organization in itself, it's a collaboration. So without setting up additional apparatus or agreements, it can't employ people directly, for example. It sort of doesn't really exist as an organization, it is a collaboration. So you just have to organize it, you have to put other mechanisms in place in order to actually deliver. So.
Yeah, I can quite imagine. And that sounds like it could be quite a challenge getting that set up. What were your experiences in trying to get that ball rolling?
Oh gosh, so it's really, really complicated, and I wonder, it might be worth just spending a bit of time just looking at what primary care networks are asked to do, what resources are available. That's the direction I'd go into to try and begin to explain or answer that question, James.
Well, yeah, I mean, that's a fantastic question, and I think probably one that our audience would be interested in finding out. What are PCNs actually contracted to do? What is a PCN for?
So I've just brought up on screen a document, so which also explains where it comes from as well. So there's the primary care network direct enhanced service, which the practice has signed up to deliver, and it's a 125-page document. It's really, go away and have a read if you're interested, if you're interested, or just actually skim through and have a look. Since being in this role, actually, I've got a bit more into reading these documents.
Reading 125-page documents.
Yeah, getting your head around them and navigating them, and often you just return to them for reference, really. But if we just look at, say, the service requirements, so what are we actually supposed to do? What are the contractual requirements as opposed to the woolly aspirations? So primary care networks are going to be responsible from October for delivering extended access. This is this business of opening in network hours, up until 8 at night, and 9 to 5 on a Saturday, for example. I'm just scrolling through just to remind myself, because there's so many. That's a big job. There is lots of stipulations on that one. It's delivering structured medications review and optimizing medicines, and these are kind of individual deliverable points. So actually, when you start delivering the primary care network, it gets really, really complicated quite quickly. There's a large part of work about delivering enhanced care in care homes and delivering home rounds. So some of the people in the audience might have been involved in delivering home rounds to care homes, and that's because it's one of the PCN DES objectives. There's work around early cancer diagnosis. Now, fortunately, a lot of these objectives were paused during the COVID response, which was quite good form from NHS England, really. So they gave us more time for some of these, but these are what we'll be doing going forwards: cardiovascular disease identification and management of risk factors, tackling neighborhood inequalities. This one's interesting because you might think this means doing something about inequalities, across large areas or between different populations, but it's really just about, within a primary care network, identifying a population which has some inequity of access or in some other aspect of the way they access healthcare, and addressing that within the primary care network population that's served by that primary care network. So it's not really about transfer of resources from, say, affluent areas to less affluent areas, which I thought it might be when I first got involved and saw.
A difficulty, isn't it? But certainly it's interesting. You can imagine that in certain areas that's actually very important, but at the extreme ends probably it means a little bit different, doesn't it?
Yeah. There's some quality improvement work around anticipatory care, which isn't about palliative care, as you might think with that word anticipatory, but it's about anticipating patients' need or likelihood to access, say, hospital care, for example. So trying to reduce emergency department attendances and emergency admissions. There's a personalized care agenda as well. So there's quite a lot in there. What else do primary care networks need to do? So there's the Impact Investment Fund. So Impact Investment Fund is a bit like QOF for primary care networks, or at that primary care network population, 50,000-ish population level. There's quite a lot of money for this. So, primary care network can achieve, up to, I think, about £200,000 if they achieve all of their objectives going forwards into next year. Again, there's a separate document that looks at these. There's also a really good sort of really good summary page that just identifies which areas are covered by the IAFF. And they're really in the areas of prevention, looking at CVD risk, inequalities, and vaccination immunization, and about providing good quality care. So there are objectives around personalized care, care homes, anticipatory care, cancer, access, structured medication reviews and respiratory care. And then there's this sustainable bit as well at the moment, which some objectives around sustainability, which for the moment seem to be focused on use of inhalers and switching to low carbon intensity inhalers. But it's really quite nice actually to see sustainability as part of the agenda there, I think. That's good. And then, I mean, I can talk about what that actually means in figures, James, if you
well, yeah, I mean, so I think one of the things that that people would want to know is, I mean, all of this sounds great, wonderful aspirations, but how's it funded? How do we actually manage to do the things that they want us to do, and suppose some of the incentives practices to get behind this? Because I mean, money is of course a great motivator for practices, and making sure that you can afford the things that you want to do, it's extremely important.
Yeah, I mean, there's a really long shopping list from the Department of Health in terms of what primary care networks need to achieve. And actually, there's quite a lot of considerable new money that wasn't previously available being put into primary care networks, which is, a positive. It's quite refreshing, really. So if we look at what the primary care network gets, and I'm going to try and zoom in a little bit here, James, and I'm just looking at the interface.
If you press Control and your mouse wheel.
Control my mouse wheel. Oh, wow. Well, that's fantastic. So these figures are based on a roughly 50,000 patient primary care network. So if we have a look, so there's something called primary care network core funding, which is just general funding to the primary care network to run itself, and that's £1.50 per patient. There's some money to fund the clinical director. There's additional roles reimbursement scheme. We'll have a look in more detail at that, because there's another tab on the spreadsheet which really goes into detail on that. £120 per care home bed to fund that home round activity and the reviews that are required within the DES, and there's quite a lot of specifics around care homes that need to be delivered. There's extended hours and extended access funding. These are actually going to be merged together to form the new extended access part of the service from October. Impact Investment Fund points. We just talked about Impact Investment Fund. So as you can see, there's up to about £200,000 available for those points to an average sized network. And then there's some additional money as well to pay for leadership and management support as well. So there's quite considerable resources going in. What isn't in this table, which we always must never forget, is that each practice are paid £1.76 per patient to engage with the primary care network as well, which is, it's not a small amount of money. And it's something that actually often gets forgotten unless you keep talking about it, because practices are actively incentivized to contribute in a meaningful way to the primary care networks. Shall we look at the ARRS table, James?
Yeah,
this is the key.
something that probably people have interacted with, you know, the new ARRS roles and the changing kind of face of the practice team. So is that part of the PCN? Is that been something the PCN has been tasked with?
Yeah, so that's probably the biggest part of primary care networks. And if you look at the funding here, this average size network, about £800,000 of that funding is for ARRS staff wages. So the ARRS, the additional roles reimbursement scheme, enables primary care networks to employ specific roles within the network. And these are very, very carefully defined in terms of what they're called and what the specification for the person you can employ in that role and the use of that role is. And if you employ a person in one of those roles, then you can draw down their salary and pay them from the ARRS scheme. So you don't get all of that ARRS money regardless of whether you employ people or not for the primary care network. You can only draw it when you have recruited someone in post and they're delivering in that role. But these are things that people have worked with PCN staff in these roles, I think. Not all of them, though. So it's clinical pharmacists. They're really, really popular. Pharmacy technicians. We've got one of those in Ball and Top Valley Primary Care Network. We've got 3 social prescribers. Just recruited a health and wellbeing coach. Really excited about that role. Care coordinators. That's one of the more versatile roles where there's a bit more freedom in terms of what you use that for. Physicians associates, so they're being deployed not in our primary care network in Ball and Top Valley, but some of the others in the city will have had experience using physicians associates. First contact physios, they've been, I mean, we can talk in a minute, James, if you like, about what impact you think these roles have had, really.
Yeah,
first contact physios, we've got those in Ball and Top Valley, dietitians, podiatrists, occupational therapists, nurse training associates. Some of these are new this year and we haven't been able to recruit in previous years. Community paramedics and advanced practitioners. And then I think they separate out the mental health practitioner separately. So last year we could have up to 1 mental health practitioner. Going forwards, 22 to 23, you can have up to 2 mental health practitioners who are employed on a 50-50 salaried basis with the mental health trust. So the primary care network can pay for half of their time and the mental health trust can pay for the other half. So so those are the roles that are available. Yeah.
I mean, you mentioned about sort of the impact of these additional roles, and I think people have had different experiences depending on who's being recruitable. You know, there's a lot of people, a lot of intention here, but I think that the training is obviously, and support of that has been quite variable. But I think that certainly I've noticed the impact of the first contact physiotherapists for, you know, doing very good work and having that experience within the practice and to be able to address some of the things that patients might have waited a very long time for. And it feels like the role has evolved a bit, and it's also really helpful to have an expert colleague in a room close by to ask my physiotherapy questions. So that's been quite good. But I mean, I suppose the impact of the others is it's a bit more difficult. And you know, we say we've had recently had a health and wellbeing coach, which is, I think it's taken quite a while to find somebody to recruit to that. I suppose the other thought that jumps to mind when we're talking about ARRS is about the PCN's responsibility for supervising and developing these roles as well. How's that been? Have you had much experience in introducing the roles as a brand new and integrating them into the system?
Oh gosh, there's so much to pick apart in that question, James. So I'll try and do it justice. So yeah, so just first to acknowledge the difference between something like the first contact physios and some of the other roles, really. So these roles come from really different stages of development in terms of what the roles actually are. So a first contact physio is it's an established, well-defined role, and we've had first contact physios for years. And in fact, we had them in Nottingham a few years ago. So that's an intervention that's really quite ready out of the box just to deploy. So you can just recruit them, bring them online, sit them in the rooms, and they know what to do. You know. So they can get up and running almost straight away. And that's a role that actually we've subcontracted to CityCare, who provide a lot of the physio services already. So they actually, within that contract, they supervise that role as well. So there's actually not that much for the practices to do. Obviously, they have to interact with them about the specifics of patient care and individual cases. But beyond that, there's not a great deal the practices need to do. So that is kind of really visible. It's good to go. You can see the impact of that straight away. If you take another role that hasn't really been in place, so I'm going to take social prescribers. It's not an entirely new concept, but in terms of the scale at which we're delivering it and the level at which we're trying to deliver it in Nottingham City, that's not really been done before. So it takes a lot longer to get those people in post, to get them inducted, to get them orientated within the community and all the community assets, and doing the asset mapping in the community, and actually develop what is needed in that role, what's going to be beneficial for the population. It's much more complex, and it takes a lot longer to get them into place. So I was first of all just acknowledging just the difference in the roles, and then in terms of getting them in role and supervising them, you mentioned some of these roles really hard to recruit. So you set recruitment targets with your practices at the beginning of the year. So we're going to aim over this year to recruit this many community pharmacists. We'll aim to recruit a community paramedic. Well, that's been really hard to actually implement, for example. So it's difficult to recruit to the roles because they're new. The staff aren't necessarily out there, to recruit.
Don't only exist.
Yeah, they don't, not necessarily there. And actually, sometimes you've got to provide a bit of a training package, to get them in. Something like the physician's associates, need a lot of kind of training and support depending on where they are in their journey. But sometimes you've got to build a lot into the role as well, which means with some of these, you've got to put a lot of effort in from the practice in the primary care network before you actually see some results out, and that can be quite a considerable amount of time. And also, some of them need quite a lot of supervision on site from the practices, and practices are busy. They don't necessarily, at least initially, see these roles as the answer. And at least at the very beginning, people were saying, "Oh, can we use the money to have some more nurse practitioners? Can we use the money to fund some more GPs?" And you have to have these conversations where you just highlight that no, you can't, because that's not what the money is designated for. There are specific roles, and then once you have these roles, if they're new, practices are going to have to spend an extra amount of time, supervising them, and making sure that they are, safe and supported. But you use some of the funding that's available from the £1.50 and other areas to try and support practices in those activities. The other thing to say is these people it gets so complicated, James. So they're employed by the Federation, NCGPA, for the most part, not all of them. But
in our PCNs.
In our PCN, and actually in most PCNs across Nottingham City, right? They're employed by the Federation because the PCNs can't employ them themselves. Actually, in other areas of the country, there's been a lead practice model, but actually these people, when they're in post, and again, this starts to get very managementy, but when they're in post, and when they've been in post for a few years, they get employment rights. So it's very difficult to, if you need to make them redundant, there's a cost to doing that, or redeploying them somewhere else. And actually there are liabilities for, involved in employing people if something goes wrong with the employment, and the employer's done something wrong. There are liabilities there, and sometimes you need to pay compensation to staff. There's all sorts of angles. So the lead practice, will be responsible for all of these liabilities, and that's a model used in other parts of the country. But in Nottingham, because the Federation, I guess, was there and ready-made and was an NHS employer, the primary care networks took the decision to largely use them as the employing body, and a lot of that was risk management at the time. So a lot of these roles are employed by NCGPA. They provide quite a lot of supervision as well, actually. And how that's been delivered has changed. There's been a lot of learning, I think, from the beginning. And it's really complicated for these staff, if you think about it. They're working within practices. So the practices are, one of their stakeholders, the people that they work for, have close proximity to them. They're actually employed by NCGPA, who are quite remote from them, but actually are responsible for them. And then you have sort of the clinical director, the deputy clinical director, and the emerging primary care network apparatus, who need them to meet certain objectives and criteria to keep the funding flowing. It's really, really difficult and complicated, for everyone involved, really, in particular that member of staff. So, sorry, James, that was a really long.
Well, no, answer. I mean, it was very clear and very interesting. And I think one of the question that kind of pops to my mind is that being a PCN lead and creating these PCNs has involved quite a lot of management, probable learning from the people doing the jobs, and that negotiation between different practices, between practices and Syndicare, between practices and the Federation, has sort of been key to getting us set up. What's been your experience with getting people on board?
Oh my goodness, it's been
a big question.
Yeah, it's been both difficult and not difficult, really. It's a really it's a really big question. I think my experience is it's been a hard job to do. And, that might be why after 2.5 years, I'm ready to move, to move on and do something else. It's been a difficult, we've not even begun to talk about COVID, and the impact that that's had on trying to deliver all of this stuff, going remote whilst trying to develop new and complicated relationships and do complex collaboration. It's, at times it's been a bit of a nightmare trying to get all of this to work, James.
Yeah, definitely tricky, and COVID throwing a giant spanner, or in fact more like a toolbox, into the works. It's been probably pretty difficult. Well, I mean, we might come on to COVID in just a second, but I was wondering a little bit about so we've got the ARRS roles, we've got the intention of the PCNs, we've got this great aspiration to bring together all the different services for improving healthcare. How did you determine where you would focus your energy, where you'd focus the effort, and sort of, we talk about setting priorities and PCN priorities. How did you go about doing that? What was the journey for that?
Yeah, it's really, really, again, I keep saying it's really difficult, don't I? That's how I'm beginning all of my answers. It's challenging. It's challenging. Yeah, it's challenging. I guess, so you got to try and be a little bit systematic about it in my mind. And the first thing is to acknowledge is that there are many masters to the primary care network, unfortunately. So the Department of Health want certain things to happen, and those things are largely expressed in the DES, or every now and again they just drop a letter on you asking you to do some new thing,
like Friday.
winter access funding, changes to when and how they want the vaccinations delivered, weight management, long COVID clinic referrals and management, they keep dropping it. So it's difficult. The practices have their own needs and objectives. The community has its own needs, that has its own health needs, and has its own wants as well, in terms of what they want from the service around things like access and how and where they want to access things. And then there's all sorts of other local stakeholders, who want the primary care network to do certain things, like the council or the members of the ICP and the ICS, have local priorities that they want to see delivered as well. So it's a bit of a minefield, really, and it's very difficult to navigate through. I mean, what we did, and I don't think we've necessarily done this very well or often enough, and I think COVID was a really big part of that, because that got us distracted on something else that was happening in the world for about 2 years, just as primary care networks were beginning to get off the ground. But I think we've got my screen up again. So
that's it.
So initially, this is a post that we did in the first few months of the primary care network, really. And we were initially given a package of information from Public Health England about the health and needs of our population. Really, really interesting data. And for our primary care network, covering the geography illustrated in the slide. And at that time, we had 8 practices. It's now 6. We lost a few along the way, which brings its own challenges as well. The picture is one of a very deprived area with the sorts of problems that you would associate with deprivation. So there's lots of unemployment, income deprivation, lots of childhood poverty. The life expectancy stat is really, really shocking in Bulwell and Top Valley. So the national average healthy life expectancy before you have a significant comorbidity is about 64. It's about 58 in Bulwell, which is 6 years.
That was the
lower.
Stat that stood out to me the most.
Yeah, and 64 is the average. So if you just go south of the river to somewhere like Rushcliffe, I think it's much higher than that. I think it's closer to 70, and I've got that on another slide somewhere. So really lots of inequality and leading to the sorts of problems that you would expect. There are more deaths from cancer. Cancer is diagnosed later. There's alcohol and substance related issues. Lots and lots of chronic pain and long-term disability in the area. Other indicators of unhealthy lifestyles around respiratory, circulatory disease, obesity, diabetes, that you can link back probably to poor health, health choices. Really, lots of care homes in the area as well. So there's lots of dementia, lots of low-level mental health. The interesting thing for our population was actually psychotic mental health, similar levels to the rest of the city, but non-psychotic mental health much higher. in this area than other areas in the city and in the ICP. So anyway, so we learned a lot about the population and spoke with track practices and tried to create some priorities around that. We had 2 exercises that were away days, one big one with the practices at the beginning. We did a lot of work in this, but it boiled down to this slide on the left, which was essentially the things that we thought that we might want to try and tackle with the primary care network on this grid, which is how impactful would it be and how easy to implement would it be. So improve staff morale and upskill staff. You see, this is something I'm not sure we ever really got there. You know,
easy to implement and high impact though.
Exactly. You know, it's sometimes worth revisiting these things. You know, care home service, we did do a lot of work on that in the end, and work's been happening around structured medication reviews. The thing is, you get a lot of other priorities thrown at you with COVID and with and from the Department of Health. 2 months
pre-COVID, wasn't it?
yeah, absolutely. And look at this, tackle obesity. So that definitely hard to implement, but quite impactful as well. So yeah, you know, we tried to structure these in a way where we thought we'd look at what we can do at the different life stages. We thought that was a nice way of trying to focus that in some aims. So, but that's not the whole story. We did some work once we'd got some staff working with the primary care network. Particularly, it was during COVID when it was difficult to bring the practice together. They were very, very busy with COVID, and you couldn't get people together face to face, and it's very difficult to do this work over Zoom. And I think the general feeling was that people had other priorities at the time. So we brought at least the staff together and looked at some. Tried to develop a mission statement, which they came up with, which is great. You know, I think people vary in their attitude towards mission statements and whether they think they're healthy or worthwhile to have or not. But anyway, this is what they came up with. And then we also have brought together the other community partners. So all the organisations and all of the services from NUH and the ambulance service and the police down to, I think there was a lady who looks after people's cats while they go into hospital, for example, have been brought together in what we went on to call Bulwell and Top Valley Health Forum. And you know, this group of people they got really good insight into the patients actually, and you know, the type of people we deal with. So they were able to inform the priorities. And of course, we've started the patient engagement group as well, which is a few meetings in trying to look at patient representation in a primary care network and help that to inform the priorities. So really describing the process for you, James. I guess at the end of this, we've got 3 working groups that are looking at what ultimately looked like were the priorities for the population, which were around mental health, were around healthy lifestyles and encouraging that, and around a specific challenge around childhood vaccinations, because that's a particular issue within the statistics of our area. So that's I mean, I hope that helps answer your question, James.
I mean, it certainly does. And to be honest, it also is about this motivating factor about sharing some of those stats and sharing some of those the reasons that people are there are important. And it strikes me actually that you went through, you were telling me you were going through went through a bit of a branding process. And what was that like? And also, why is that important for getting this sort of thing off the ground?
Yeah, so the branding process was driven by the staff essentially. It's really difficult. I've tried to do it before actually in other organisations. Why is it important? Well, I think it's about identity. So essentially at the beginning, what the primary care network is you know, it's a collaboration to try and the practice has been brought together because NHS England have told them that they need to be brought together to meet some objectives that they weren't necessarily originally interested in meeting, but they get some resources, and actually a byproduct of using those resources to meet the objectives should be that life gets a little bit easier for general practice. Debatable whether that's going to happen, and there's all sorts of things constantly making life a bit worse for general practice as other things try and make it better. So it's difficult to see what the results have been, but it's not really a thing at the beginning. And of course there's other stakeholders as well. So in order to begin to meet its own create its own objectives and then try to meet those objectives, it needs an identity. You know, it needs to be a thing, particularly when you're going out to other organisations outside of the core practices to say, can you collaborate with Bulwell and Top Valley Primary Care Network on a project or to deliver something? It really helps if you are a thing that has an identity, has a direction, and you know, has things like a logo and things like that that you can put on the bottom of an email, that you can put on slides, because it actually improves the confidence that other organizations have in dealing with you. So there's all sorts of reasons why I think branding is useful.
Yeah, I think that's absolutely right. And I suppose the thing that struck me is that I'm not sure I would have even thought about it had I been put in your situation. So I think it's super important that when people go, well, with the Bulwell and Top Valley Primary Care Network, people don't go, who? But in fact, they go, like, I've seen your logo. I've seen, you know, I've seen the posters about this.
They probably still go who, but we're trying.
Yeah, but it's steps in the right direction, isn't it? You know, hopefully PCNs will be a nice, stable organizations going into the future. I think I had one final question sort of for this little section was, I mean, we've mentioned COVID and its impact on sort of the anticipation of what the primary care networks are going to do. I suppose, what changes do you think that brought to the PCN priorities and focus? And we touched on it a couple of times, but evidently it must have been a real challenge.
Yeah, COVID was a real challenge because primary care networks were, you know, really, they were less than a year old, you know, about 9 months old. And there's a lot to do in terms of setting up an organization like a primary care network. So they were really in their infancy when COVID hit. And I think they were a convenient sort of unit of organization for NHS England to sort of commandeer, really, to help it deliver the response to the coronavirus. So it felt a little bit like we got took over by the top-down agenda dealing with the COVID pandemic, you know, and rightly so, to be quite honest, because it was an international crisis and needed a really, really big emergency response. But we weren't really able to progress the objectives that we originally thought we were progressing, and it became largely about COVID for quite a long time. We did get on with other stuff in the past, and I think we've achieved, you know, quite a lot actually. But it largely became about COVID. There's positives and negatives that I think that brought. So probably the positives in the end outweigh the negatives. So what it made us do was, with the practices, we had what were weekly meetings for quite a long time between the practices, talking about how we were responding to coronavirus, calibrating the response, you know, what were different practices doing, and actually just being co-supportive, because it was a really, really challenging time. I mean, if we remember what things were actually like during the first few months. And I think that brought the practices together, actually. I think it gave the PCNs a purpose to be coordinating this response. So I think that was helpful.
And crises bring people together, of course.
Absolutely.
You know,
and we had some successes. So we've been delivering vaccines more recently, but in the early days we were organizing, I'm going to call them hot clinics. We weren't supposed to call them hot clinics. They were supposed to be clinical management centers. But, you know, we had one in our building, James, if you remember, that covered, initially the PCN 1, which is us, and PCN 3, the next door one, but actually it came to be the COVID management center for the whole city. So actually getting something like that up and running safe and staffing and manning it was a really, really huge challenge. I remember, so I think it helped relationships in general, but I remember in that period, we as clinical directors and primary care networks were being leaned on by NHS England, the local people with NHS England. It felt like this, and it was, because it was a crisis, to make certain things happen, like the clinical management centres. And in turn, that meant that we had to sometimes lean on other people in a way to make things happen. And I remember having some difficult conversations with staff from one of our practices, you know, giving them a tour of what the clinical management centre would be like, and having very difficult questions about ventilation and about the level of personal protective equipment that would be provided, and that wouldn't be what they, and frankly what I thought was necessary at the time. And that was really, really challenging from a leadership perspective. And, you know, and some of the people on that tour did work there, and, you know, I think we did a good job, but it was really, really difficult. The final way that I think it's not been helpful is that it took all of the communication to Zoom and video and email. And that's really good if you've got really strong, fairly good if you've got existing strong relationships and you're kind of carry on doing what you've already been doing in the way you've already been doing it. But if you are trying to develop a new organization, develop new relationships with people you've not worked with before, collaborating on new and complex things, that's really, really hard to do via Zoom. And actually, what you lose is some of those interactions before and after meetings, when you can just check if people are feeling okay. Are they really on board with what's happening? You know, you can do that soft element of leadership and managing people, and you just can't do that, or it's very difficult to do that with video meetings. And actually, I think you find that actually you erode relationships if you're doing difficult and complex things for a long period of time with video meetings. Whereas if you're meeting face to face, you've got the opportunity to maintain, rebuild, build up goodwill and relationships. So yeah, so COVID, yeah, pluses and minuses, but at least it gave us a purpose and kind of brought us together in a way, I think.
Yeah, I think bringing people together from a sense of purpose is super important for starting out on PCNs and other organizations. It sounds like in adversity, there's actually something pretty great that has risen from that as well, but I can appreciate the challenges. I mean, segues us on quite nicely to the other thing that we're going to talk about today. It was a bit about leadership throughout this, which a lot of people attending today, I think, would be very interested about. I mean, through this journey, through being sort of, you know, one of the first ever PCN directors ever, you know, it was a new organization, you were the first PCN director. What do you think you learned about leadership? What do you think you learned about leadership and leading other people throughout this?
So much is the first thing to say. Well, I boil it down to a few things. And the interesting thing is the organization it's changed over the years. So, you know, initially it was myself and a deputy clinical director and some practices. And now there are, you know, 4 to 5 clinical pharmacists, there are 3 social prescribers, there are multiple first contact physios, you know, there are lots and lots of staff you know, involved. There's now a network manager. So they're really, really different things. And actually scaling was really, really challenging. Some specific things I've learned. So and these are quite obvious, but you kind of just learn them in a visceral way when you're actually doing it. You know, if you do a leadership course, you know these things, but you learn them in a visceral, real way from actually doing them. So communication, so important. And so compromised and challenged by having to go all video. And I think that I could have done that better, I think, really. And it's communication both ways, and actually going video impairs your communication both ways as well. And you know, if I had my time again, I'd do a bit more to mitigate those problems. So you can't listen so much to what the stakeholders want. You know, they're on a call, often they're behind a black box, you know, to actually know what their needs are, what their priorities are, whether they're on board or they're just saying they're on board. It's really hard. So that listening element of communication is difficult. And then actually getting your point across and out there, and, you know, being supportive and kind of doing the soft bits of proactive communication is hard. And just communicating, you know, what is happening, it's just really, really hard. And to do it right, the volume of communication that you need to put out there in terms of updates and so forth, it's a challenge. So, but just the importance of communication and how getting that right in both directions is really important. The other thing I would say, the
number of meetings that you ended up having to go to try and mitigate some of that.
Yeah, you saw a bit of my calendar, didn't you, when we were setting up for this?
It's eye-watering.
Yeah. And people don't see it because it's not just the practices, it's all the other stakeholders that are involved and certain elements of managing the staff, particularly when we didn't have a manager on board. Another thing is get the manager on board earlier. Although I was talking in the first few meetings of Primary Care Network about how we would probably need a manager, but it took us about 2.5 years in to actually get a network manager in post. I would have loved to have done that earlier, which I suppose leads me on to delegation. And this is about, and there's so much there. Delegation. Yeah, the principle is easy to say, isn't it? But it's actually, what's your system of delegating? What do you delegate? How does the person know what they need to do? How do you know that they're doing them? You know, what's the reporting system? What's the reporting format? How frequently you're checking in with them? You know, is that via a meeting? Is that via email? Actually setting up effective systems of delegation for, you know, a medium to growing into a larger organization is really complicated, particularly if you're not a manager, you know, and particularly if you've just funded for a day a week, you know. So delegation, actually the importance of getting some management infrastructure in there. And I did talk about it, but and you know, we're not particularly behind in PCN 1, but I think those PCNs that got their managers a little bit earlier have shown how effective they are at helping the PCN grow and be effective. So I'm really excited that we've got our manager Alex in position.
I wonder whether, you know, GPs, just being a GP does make that delegation, you know, quite difficult. It's not something we're very used to as general practitioners. You just kind of just take it on and do it yourself quite often. And I think that's a good lesson for us all to learn, really, isn't it? Okay, so I mean, how did you, I suppose there's lots of people you've had to interact with, so other practices has been very important. What did you learn about sort of leadership role with the practices, but also with the wider system? How did you sort of integrate yourself with all the different, you know, lords of the land that are all asking different things for you? How did you deal with that as leadership?
I'm going to make an observation first, and that is, I think the practices are more difficult actually, because for the practices, the primary care network might be seen as an additional have to do, essentially, because it's sort of a contractual requirement to get resources. And practices really, they're the small businesses that really run lean, and they've got their own stuff to do. So particularly in the early days, now there's more resources around the primary care network. There's a lot more interest, I think, from practices, but actually holding the interest of practices, I think is difficult, particularly in the early days. So there's a challenge to kind of interest and engage and inform there when they're so busy. The other wider stakeholders, I've found it actually a bit easier to engage with that group, because often you are useful to them and you're a resource to them in a way to deliver some of their objectives that they have, because they often have objectives around population health. They are encouraged and used to working with other organizations because they are larger organizations themselves. They have people who, you know, it's their job to engage with you. So in some ways, they're more, they get on board a lot more easily, the bigger organizations, like the likes of City Care and let's think of other examples. The Mental Health Trust have been quite good to work with, for example, on the mental health practitioners, just to give two examples. So
I suppose they're not looking at the bottom line so much as well. You know, they're doing work of which this is part of it, rather than, you know, having to think about money coming in and payments and all of that kind of stuff. That must complicate things quite a bit. Yeah.
I think you've hit the nail on the head, really. So yes, there's so much to learn from doing a role like this.
How about, I suppose, one of the things that you would have had to learn is a bit about crisis management. What do you think is important in the midst of a crisis? What do you think, you know, through COVID? So you've become the director, you've had that nice meeting beginning, and 2 months later, bang, here's COVID. What did you learn about sort of crises as a leader?
That's a big question. I think it's hard to answer, James. That's such a broad question.
Okay. Okay, maybe more specific. How do you, when you're faced with a crisis, how do you approach it? How does your leadership style approach that emergency that has happened?
I mean, I'll tell a story, really. So let's take the beginning of the coronavirus crisis. So it's really had a really, and I was part of that communication eventually. They pulled all the clinical directors into a meeting and said, look, this is serious. And, you know, we need to do a number of things, and we need to go to face-to-face, you know, telephone appointments. You know, the country's going to be locked down. You have to support people in an entirely different way. And that was really, really scary. So first of all, it's about just making an assessment of what the crisis is, what's required from you, what's required from the resources that you control, or not control, but that you are responsible for directing in some way. And then you have to communicate that to the people that you need to take action, and be clear about what you need them to do. So I remember putting together a few slides that were just very simple about the flattening the curve graph. That was really, really useful to just say, right, we just need to flatten the curve. So this is about reducing contacts between people, which is about keeping people out of surgery, you know, keeping them at home. So yeah, there's something about just being clear about the objectives, and then about having clear communication, but communication that tells people why they need to do things, as well as what they need to do. And then also just having regular check-ins. We had a meeting every week. And I think in the first week we might have had more than one meeting, to be quite honest. I think we might have had daily primary care network meetings for a little while, and then checking in with people, because a crisis, it's not just like that. Actually they go on for quite a long time. So you have to sustain a crisis response for a long period of time. You've got to pace people. And we had some conversations, particularly in practice, James, you might remember, just about pacing, not going too fast, too quickly, and burning out. And you've got to kind of sustain that motivation and the communication going forwards, and things evolve. So you've got to make sure you've got the systems to get new messages out to people as they evolve. It's really interesting, and you know what you're into. So yeah, crisis management. Yeah, that was an interesting experience.
Yeah, well, certainly a big learning experience. And I think that what I draw from what you say there is that, we talk about crisis mode, but crisis mode means different things to different people. And with this kind of considered approach, which I think being also on the receiving end of it, with the good, great communication that you did, I think was really key. So that's probably what I take away from that. And I think that maybe leads into another question. So what did you learn about motivating people and keeping people on board during PCN development? I suppose COVID as well. We talked about a bit about that. What have you learned about motivating people as part of your sort of leadership journey on this?
I think the crisis management might be a bit of a microcosm of that, really. Just the importance of actually, there's more to it. So yeah, knowing what needs to be done, communicating it effectively, regularly, checking in with people. About motivating people, it's about actually just understanding what their needs are as well. So I think it sort of begins with listening, really, so you can understand the person or the organization that you wish to motivate. And it's important to look for the synergies, in terms of what you sort of need to get done, to move the primary care network forwards, and what they need to get done to continue to functioning effectively as a practice, to grow as a practice, to be effective as a practice, to be more effective as a practice. And where you can see those synergies, that's often where the motivation is as well. And and it's understanding do they see the synergies, or do you need to explain or communicate things in a different way so that can be appreciated. It's complicated. There's so much to say about motivating people, isn't there? And it's how you frame certain things, because if you take the new extended access, for example, that's just landed in the last few weeks, some of the initial headlines in the press and some of the initial response on social media was
quite visceral.
We're all going to have to work until 8 every night. And in Nottingham, that's not necessarily the case. And actually, the other way to frame that is, well, actually, this isn't a new ask that people are being asked to do. There currently is extended access in Nottingham that's provided from Upper Parliament Street by the GP Plus service, and general practice is not being asked to do any more hours. It's just that those hours are shifted out to networks. So there's already a workforce working that. They'll probably still be interested in working it. It's just an exercise in that those hours finding a new place to work. So it's not necessarily that the existing salaried staff and partners at practices need to work those hours, but there's gonna have to be some adaptation to get those hours worked. But potentially there's a workforce already doing them. It's not necessarily that bad. So sometimes it's about just how you frame things as well.
Framing and communication sound really key in this situation. I suppose during this time and with that, you've got to try and convince some people to do things they don't really want to do in some cases, or might have to do. How do you approach that as a challenge? Because so
it's difficult, isn't it? And the key thing is that they don't have to do them, I guess, is quite key, because sometimes people do have to do things because they're contracted to do them, and sometimes they don't because they're optional. There's all sorts of ways. I'm trying to think of some examples, but working with PPE that people didn't feel was adequate at the time, for example, in clinical management centres. I mean, sometimes it's about people vary in their degree to get on board with these things. So there was some. Let's just take that as an example. So you have to acknowledge some people are just not going to do it, but to be a success, not everyone needs to do it, because some people have personal risk factors or their attitude towards the risk is different. So you don't necessarily, depending on the situation, need to convince everybody. And then for those people that will do it, I mean, sometimes just being paid for it, you know, is enough. So, okay, well, you know, is the pay remuneration in the right place? Actually listening to people. So, right, okay, you've got concerns about PPE. So maybe we don't have FFP3 masks for general use. It's surgical masks, but actually for aerosol generating procedures like CPR and things that you might have to do, FFP3 masks definitely here. So actually just understanding their concerns and showing that you are trying to address them and getting down to the specifics can be really, really helpful. You know, sometimes you have, you know, sometimes this is a national emergency. You know, if these people are not seen in the clinical management center, then you will need to see them at the practice. You know, they are going to come to the practice. And at least in the clinical management center, the setup is, you know, we have a large area, it's less populated, there's ventilation, the other vulnerable people aren't around, your other vulnerable members of staff are not here, they are in a different place. You know, maybe this is, it's a crisis and this is the lesser of evils, you know. So there's all sorts of tactics, I guess, that you have to try and use to make something happen that needs to happen.
Yeah, finding what motivates people, and I suppose finding levers as well can be quite helpful.
Yeah.
I mean, it sounds like you've gone on a really massive journey through this and through PCN, you know, through the creation of this. Throughout all of this, what have you learned about yourself, do you think? What epiphanies or thoughts have you had about yourself as a leader, you know, as a person as part of this PCN system?
I suppose first of all, there's sort of personal, you learn a lot about your own strengths and weaknesses, and you know, sort of personal limitations, and so you know, it is possible to get a bit burnt out, to get tired, you know, and you know, have I experienced that before? I probably have, but you know, it really can happen. So you have to be careful and pace yourself, and that's difficult. So that's good. And I guess, you know, it's difficult, isn't it? But I think, you know, just the importance of communication, and you know, you might think you're a good communicator, but are you? You know, and you know, that's, you know, I'm constantly reflecting on communication, and I always want to improve in that area. I'm just trying to think. It's a really, really good question. I feel like I'm at the interview for the next job here, James, in some ways.
You're inspiring the next generation as well, and you know, practice for bigger things now that you've got the PCN under your belt.
And hopefully, and hopefully it's inspiring, because it's a hard job. It's probably not for everybody. It's not necessarily something to jump into from from first five, you know, or something like that. But it is rewarding, and you know, you can learn so much about yourself and about the system. You know, and make an impact. I mean, I think primary care networks are going to have an impact on population health. I think we've been derailed a little bit with COVID, but I think those improvements and the collaboration with the wider community services is coming now, particularly in Bulwell and Top Valley. I think practices are increasingly on board, particularly now that the resource level is really ramped up. You know, people are interested now, which is really, really healthy. So I think the future's right. Yeah,
I think so too. I mean, and the initiation you've had, and you know, the things you've learned about communication and motivation, I think sound like they've really set things up for success in the future. So you know, I think we're all very grateful for that. I suppose the final couple of things I wanted to ask you about was throughout this journey, throughout the creation, the setting up of PCNs, what do you think has been the biggest challenge? What hasn't gone so well during it? And then we'll finish with, what do you think has gone really well? What do you think the greatest achievement of this is?
So what didn't go so well? I'll just give you two things. So communication is so hard. I keep talking about communication.
Key.
But and it's the volume, and it's not just meetings, it's emails, and it's just relentless. So that's been a real challenge, just kind of keeping up with that without going crazy. So that's a personal challenge, I guess. Yeah. What didn't go so well? I think there's something about scaling up, you know, going from that 2 people and a group of potentially practices that could be more interested than they were, to you know, to an organization that employs lots of people, you know, looking at, you know, having, you know, 1 point whatever million pound, you know, budget, you know, coming into year 3, and that goes up, you know, through to year 5 of the primary care network. There's something about just scaling, and I think I would have loved to have had a network manager sooner, and to have just had an eye more on the scaling. But equally, you know, we're not business people, you know, and equally, you know, I'm not sure the majority of primary care networks necessarily have handled that particularly well, but just to have an eye on the scaling early, and we identified this early on. We said, look, this is what it's going to become. We need to scale effectively. Yet I felt that we could have scaled better, and the key to that would have been having a network manager on board sooner, I think. So that's where I would have liked to have improved.
Yeah, having the right allies and having the right team is super important. And I reflect on that from some of my own projects recently that kind of trundled along for 8 months, not really getting anywhere. And we got 2 key people on board. Bang! It's, you know, it's aiming for the stars now. Okay, and brilliant. I mean, so, and what went well? What do you think has been the biggest success here with PCNs, and I mean, you know, and particularly your impact in this? You know, your impact on.
Okay, that's interesting. So, so I think in some ways the communication's gone well as well. You know, there have been times when it's really worked well. We've had good meetings in crises. So there's a positive side to that. It's just really great to see roles in place now. You know, first contact physios have worked really, really well. As of all the roles, really. We've got our clinical pharmacists, we've got our social prescribers, we've got a health and wellbeing coach on board, who I think is going to be fantastic. Actually, I think that role's really, really, really interesting, and speaks to some of these wider determinants of health around lifestyle choices. So I'm really excited about that role. And there's many more roles, you know, to talk about as well. Probably the thing that I'm most pleased with in Bull and Top Valley is actually the work that we've got moving on population health. So bringing those partners together in the middle of the COVID crisis. So we decided we just couldn't wait any longer. We thought, right, even if it's virtual, we need to bring together all of these organizations that touch the health of and well-being of the population of Bulwell and Top Valley. We actually managed to get them together. We including the local MP and, you know, local councillors and, you know, all sorts of stakeholders. And we now have Bulwell and Top Valley Health Forum. So we made a thing of it, and we said, we are going to meet quarterly, all of these people, and we are going to support each other, because it's tough working in a place like Bulwell and Top Valley, but can be rewarding. We're going to support each other, communicate better as organizations. So it's a place where they can exchange information and work on projects. And actually we're doing real things around the working groups around mental health, healthy lifestyles and childhood vaccinations, and we're really getting that going, and it's true community collaboration. And we were a trailblazer site for primary care networks to do this sort of work, and we've just been awarded some accelerator funding to continue this work. So I think that's been really, really helpful.
Brilliant. And I think that's really wonderful. It sounds like there are great things in the work, and it sounds like you know, well, definitely you're instrumental in getting these things set up, and it's really been interesting to hear about your leadership journey and the things that you've learned along the way, and definitely some brilliant messages from that. Well, I mean, thank you so much for your time today.
One more thing to say. So,
go for it. Yeah, please do.
One group that we never. So a big challenge was actually getting beyond the board members and the partners, and actually engaging the wider staff with primary care networks, and I don't think we've cracked that yet, at least not in Bulwell and Top Valley, and probably the challenges there in other areas. So I would encourage those people watching, be they locums, be they salaried, be they partners, to just learn a little bit more about your local primary care network and offer to get involved. We do now have funding for leadership and management. There's some additional funding for that this year and towards the end of last year, to create additional kind of part-time roles, or like, you know, half a session or a whole session a month, for example, to manage some of the care home objectives for the primary care network. There are good opportunities for people to get involved doing interesting work and be paid for it now within primary care networks. So I just really encourage the audience to learn a bit more about primary care networks. You might find that there's some interesting work that can be done, that you can have fun doing, that's different to seeing, just patients in the day, in the 9 to 8 p.m. grind,
Yes.
and that will do a service, for the population. So I just encourage people to go out there and learn a bit more about getting involved in primary care networks.
Well, I think that's right. I mean, and I think you demonstrated just how much an impact that that GPs can have on the local area. A partner in a practice that that's sort of stepped up to help coordinate all these kind of stuff and found abilities and found community lessons throughout this process. So really fascinating, really an inspirational story. So thank you so much, Andy. It's been really great talking to you about this, and I think the opportunities for our newly qualified GPs, in fact for all GPs, but particularly newly qualified, with ideas to get themselves involved and make a change.
Absolutely. Well, thanks, James. It's been a great opportunity to talk to you and to talk to the audience.
I'm really, really grateful, and I hope we'll imagine that there'll be even greater things next. We'll keep an eye out for what's next for Andy Foster. Thank you so much. Cheers. Take care. Bye.